So this topic is a fairly new topic in the United States. We really only started talking about repairing meniscal roots, especially in older patients or medial roots, over the past 5 years or so. We call these underserved tears. The root tear, the radial, I think they'll talk a little bit more about this going forward, but really it comes down to what not to fix and then how to fix it if you think it's an operative case. So this is a very typical patient, 44-year-old female. She tripped and fell when stepping into the tub, but a very low injury, trauma, immediate posterior knee pain. She complained of some buckling in her knee. X-rays look normal, and here you can see that posterior horn of the medial meniscus detached from the root. And so this is what I instruct our fellows and residents to look at first. I think looking at the Fat Suppress series first, especially if you have suspicion for a root tear, is really important because these are often missed in the United States even by our radiologists. So I think it's important to take a good look at the chondral surface because if there's significant arthritis, your repair is going to fail. And then I would say the first thing you do when you get into the OR, when you're looking into the medial compartment, is pie crust the MCL because you're not going to be able to do a good job with this surgery if you can't see well. So some little pictures here, just how we start out. Typically you can do this in different ways, but the first thing I do is I clean out the attachment site or the recipient site by using a curette. As far as making this movie play, I guess.
Video.
Here, any kind of curette. This is just a regular curette. We also have, in some of the sets, there's cartilage curettes to just get a good site for healing. You want to get down to bone, ideally a little bit of bleeding bone. And then there's lots of different ways to pass the suture. There's different suture passers. There's reusable ones. There's single-use ones. I typically use a looped suture tape, but you can use any kind of high-strength suture and create essentially a luggage tag. Here you can see there's a simple stitch and there's a mattress stitch. I think you don't always have a lot of options as far as what kind of quality the tissue is, and certainly the tissue needs to be good enough quality to hold the suture. This is an animation using a Ceterex, and you can see this allows you to not have to bring an instrument in and out. You can do it all with one suture passer, and then you can bring the suture out and create a luggage tag. I think this is a good way to do it, but again, there's many ways to get this done. As far as actually drilling the tunnel, I personally like to pass my sutures first because, as I mentioned, the quality of the tissue is not always particularly good, and if you pass your sutures and they don't hold in the meniscus, you're done. You tell the patient typically in advance that this may not work. You're going to go in and try, and that there's several reasons you may abandon the surgery. For example, if there's too much arthritis, if you see a significant cartilage defect. But again, there's different systems. This one depicted here is specifically for root repair. When I started doing the surgery, I just used a regular ACL guide, and depending on where I'm operating, that may be the only equipment that I have. It's difficult with an ACL guide to get posterior enough, so the guides that are specifically designed for this make it a little bit easier. Here you can see, once I've placed my guide, here you can see the pin coming right up into the root site. And then, again, there's many ways to fix the sutures. So you can fix the sutures by just tying over a simple button. Some people pass 2 sutures through 2 tunnels, and then you have a bone bridge. I typically use an interference type screw, typically a swivel lock, but there's also footprint anchors as well. And here you can see just shuttling the sutures actually down. You can see that here I essentially did 2 link suture tapes, and you want to be able to, before you're done fixing it, you want to make sure that you have really good tension. It's impressive that sometimes you're now make a tiny incision over the proximal tibia, and you'll find that when you look back in the knee, these sutures aren't particularly tight. So before you commit yourself, definitely take a look arthroscopically. And here you can see good x-rays. This is tied over a button. So what do you tell your patients about this? Is this going to work? As I said, the first thing I do when I talk about this to a patient in the office is I tell them that it may not work. So here one study showed about 70%, or 69.7, at second look arthroscopy had actually healed. And these patients, typically we keep non-weight bearing for the first 6 weeks, so it's a much higher risk of DVT. There's also several studies showing that root repair improves contact mechanics. We did a study last year, we haven't published it yet, but looking with our knee simulator, which simulates gait, stair climbing, etc., and if you can get the root back to the footprint, your contact mechanics are improved. Here again, look at this MRI. You see the meniscus coming across the posterior aspect of the medial compartment, and then you see a ghost sign, or just this lighter area where the root has detached. There is some data that meniscal repair is cost effective, and that's becoming more and more important in the United States, and I'm sure around the world, as far as looking at risk of arthritis. So if you can repair the root and actually get it to heal, the risk of progressing to osteoarthritis is substantially less. In this study, it was 29% versus 39%. So it's not that you're going to avoid it altogether, but lower risk of knee replacement as well. And again, another study just looking at 10-year risks of developing osteoarthritis, as well as the cost being less. Thank you very much.